I want to say, first of all, is a big thank you to give us this opportunity, because this is a hugely influential learning place. And Alan's just been telling us about all the different medical professionals that now come together to deliver primary care. It's no longer just the GP, it is a whole host of medical professionals, and hasn't it enriched the offer that we can give to patients? I mean, this is what it's all about, offering quality care. So a big thank you for that. And then I want to say thank you to my two compatriots in Bowell, that's Kuma Eunice and Jim Lee. And the three of us do the cases gastro. And we have a lot of fun as well, and we've got a very good mentor in Kumar Basu. And what we've noticed over the, I think it's nearly 4 years now I've been doing this, the quality of referrals that's coming from primary care to us to look at is getting better and better and better. And that's a big thank you to the population of Sheffield GPs and all referrers, because they're not all GPs, are they? The people that are sending these letters in. And we're getting iron deficiency anemia, and guess what? The celiac antibodies are in place, and all the bits and pieces have been done. So the cases work that's carrying on in Sheffield is very valuable, and it's been recognised at national level. And there's a programme called Getting It Right First Time, which I'm part of now, because they recognise the Sheffield work. They asked me, how do you do it? So Emma's been very supportive of this and keeps giving us figures. So what we're doing in Sheffield is actually leading the way for improving quality of care for patients, because it makes it more available. So my brief this afternoon is to just bring you up a little bit on some new gastro stuff that's come out in the last couple of years. This is my declaration of interest, and I'm currently the chair of the Primary Care Society of Gastroenterology. And we have developed a training programme to develop GPs into a GP with special interest. Now, Alan was talking about training, and I'll tell you a very sad story about my greenhouse. The roof got blown away in Storm Arwen last weekend. So that's very sad, and things don't always go according to plan, do they? But we've got this very good 2-year training programme that has been funded by NHS England, and you can develop yourself into a GP with special interest. So then you could be employed by a PCN or a hospital trust or an ICB to do the same sort of thing that we're doing in cases, but possibly at a higher level. So I wanted to let you know about that. And the other thing that we do in the Primary Care Society is a series of podcasts. So this is what we've been talking about. And we do one every month. And these podcasts get various hits. So when I'm talking about top of the Plops, what I've chosen are the 10 top most popular podcasts that GPs click on, and they must listen several times, I think. And so we'll go through it, and there's some really quite interesting stuff that you perhaps don't know. So this is me, and I can see a few of my colleagues on the front row, and we work at next door to Lidl. Where are you? Oh, next door to Lidl. And we've been there 11 years now. I can't believe that, because we think of this as our new surgery. And I'm in room 3, and across the corridor from room 3 was this door. And you sort of think, what's that then? What can that possibly be? So I Googled it, and that's what you get. So I know somewhere in this building, Joe Marr is doing the Move More afternoon. Well, this takes Move More to a new level. So go all different places giving out bits of advice about gastroenterology, and they say, well, where are you from then? I'm from Sheffield. Okay. What do you know about Sheffield? Well, they've got a football team. Thank you, Sheffield United, for hosting us this afternoon. Yeah, they've got quite a good football team. In fact, they've got 2 football teams. Keep it fair for Sheffield Wednesday. You know, sometimes we go there, sometimes we come here. But do you know the one thing that really people resonate with? They say, well, that's where the full Monty came from, isn't it? So, yeah, actually, you're absolutely right. OK, now, by the end of this afternoon, you will know the answer to this question. And for the ones over here who can't see it, what did the kimchi say to the sauerkraut in the colon? So if anybody has to leave before the end for school pickup, you will never know. So you've got to stay to the end. Right, OK. So what we're actually going to do is a journey down the bowel. We're going to start at the top of the esophagus. We're going to all work our way right down to the colon at the bottom. And I'm going to tell you things that you probably never knew. So Barrett's esophagus, why is it important? Because 1% of us will develop it, and 10% of them will get cancer in their lifetime. So that's why it's important. People with reflux, have they got Barrett's? Should we be doing anything about it? Because potentially it's a pre-malignant condition. The risk factor. Now this is what we're good at in primary care. We talk to these people all the time, and our whole primary care team is constantly reminding people about their weight, about their smoking, about the reflux, the family history. There's lots and lots of contributory factors here, and we're the people on the front line that can point out that the lifestyle is making their health worse. The biggest risk factor of all for the development of Barrett's esophagus is reflux for more than 10 years. So these are the ones, they're doing a medication review. You're still on that lansoprazole. Ooh, how long have you been on that? Oh, must be 10 years, doc. They're the ones that we need to be sending up for an open access endoscopy to see if they've got any Barrett's epithelium. Have a look. That is a picture of Barrett's. Now, you just have to take my word for it, but you look down, most of it is pale pink, and then at the bottom, you get some extra red pink. And that's because the cells that are normally lining the inside of the stomach come out because of all the acid that's in the esophagus where it shouldn't be, and it creates that almost like a chemical burn. There is a move to develop transnasal endoscopy in the GP surgery. So with the transnasal, you put the endoscope up the nose, you spray the back of the nose, and it goes up the nose and down into the stomach, and technically you can do it in your consulting room. There's various training courses for GPs, and it's one of these move it out of hospital schemes that the government's talking about. The other thing that's new with this, two lady consultants, Cambridge and Ipswich, have developed the cytosponge. Now I'll show you this. This, just see if I can get you this. Right. So this is a cytosponge, and instead of having an endoscopy, you swallow this cytosponge. And when I was telling somebody I was going to give this talk, they said, all right, okay, well, you can do a demo while you're giving the talk. Swallow the sponge, and then pull it back up again. So watch this. I'm not going to do it. And you can imagine, can't you, pulling it back up again and sort of spitting it out. But in my next slide, you can see there it is, less than 2 centimetres, so it is possible to swallow it. And once it gets into the stomach, it bursts out of its little shell because you digest it with the acid in your stomach, and out comes this cytosponge, which you then draw back up the esophagus, and you can do lots of things. And in a couple of the other scenarios I'm going to show you in a minute, it collects all sorts of things. So you can gather Helicobacter if you're in the stomach. You can gather malignant cells if you're looking at either cancer esophagus or Barrett's esophagus. And in a minute, I'm going to talk about eosinophilic esophagitis, and you can measure the eosinophils. So this very simple little bit of kit may be coming to a post office near you, because they're doing a lot of it by posting it out to patients. And they've done 2 big studies, and Charlie, my pal through the Gastro Society, he's done a big project in Bristol. So this is a new thing, and it's on its way potentially to Sheffield. Right, I've got this upside down. Oh, I've got to point it that way. Yeah, sorry. Right, so the other thing in the esophagus that nobody really seems to have got their head around is eosinophilic esophagitis. Now, commonly, people come to the GP and they say, GP, I can't swallow. It gets down here and then it gets stuck and I have to cough, and I can manage to get it out of the way. But basically, what we're talking here is young people with dysphagia. So, of course, GP think, oh, great, that's fine, that's easy, 2-week wait. And they all pitch up at the endoscopy list. Well, of course, none of them have got cancer. But what they have got is this. So the backstory to this is that Stephen Atwood, who's a consultant in training in the early 80s, he was waiting for his money to come through for his grant. So they said, well, you've not got anything to do, Stephen, for 8 weeks, so you can count these cells in these biopsies. So he spent 8 weeks counting eosinophils from a group of patients, eosinophils from esophageal biopsies, a group of patients who presented with dysphagia. And what he found was that this is the commonest cause of a food bolus in young people. So now if a young person goes to A&E with a food bolus, they get scoped, but they get esophageal biopsies. And that's how you get the diagnosis of eosinophilic esophagitis. And if the patient ends up on a 2-week wait, which is some of the endoscopy lists that I do at the Hallamshire, they will all get esophageal biopsies, and you'll get the report coming back to you, say biopsies being taken to exclude eosinophilic esophagitis. And I often wonder if people really know what that is and what they've got to do with it if they get the results. Well, the results go back to the consultants to look at, and then the patient would get recalled to clinic. So it's something that's increasingly recognised. So who gets it? Well, young men in their 30s, anybody can get it, but it's often young men, healthy people, 1 in 1,000. So, you know, if we've got a list of 14,000, we've got 14 people with this condition. It's an allergic response, so nobody really knows much about it, but it's thought to be an allergic response. And then you get inflammation, then you get scarring. The scarring causes tightening, and then that causes the obstruction halfway down the gullet. Fibrosis, narrowing, so that's why the food gets stuck. And it's meat and chips that get stuck. Soup will go down, tea will go down, but solid things get stuck. And a good proportion of present as an emergency, and that's how they end up in A&E. But some of them obviously come to the GP and you think, oh, that's an easy one, 2-week wait. You know, that's what happens. So why does it happen? We are too clean, apparently. Something to do with food processing. The diagnosis has to be made by endoscopy. There's no other way. And the treatment initially was with a PPI. And it's one of these serendipity things, because PPI actually does work a little bit, and it's nothing to do with acid, but it modifies the cytokine pathway. NICE. This is the new bit for your learning. Oh, sorry, diet. You can go on an elimination diet, but if you didn't eat wheat, meat, eggs, soya, legumes, if there's not a lot left, or you can do just wheat and milk, which is nearly as good, but not quite. Or, this is the new bit, NICE has just approved a medication called Jorveza, which is budesonide, which you put on your tongue and it dissolves into sort of like a sludge, which then dribbles down the esophagus, coats the esophagus with budesonide. And it's a bit like putting Betnovate onto eczema. And it's cleared by the first pass metabolism, so it's not a big deal in terms of steroid. Very little systemic side effects. You might get a bit of thrush in your mouth. And it's coming soon to a shared care protocol near you. So watch this, because it's going through now, and the intention is that it will become a shared care prescription for us. It's very, very safe. It can't do anything bad. And currently everybody has to go to the hospital to get their prescriptions. Follow up, repeat endoscopies, but this surely must be a big new application for the cytosponge, because endoscopies are horrible. Okay, right, so the learning there, new drug, Jorveza, coming up, eosinophilic esophagitis, a big cause of food bolus obstruction. Now, no talk on gastro would be complete, would it, without mentioning Helicobacter. So, the bad news is it's passed by kissing. So if you have a burp and then kiss your partner, they're doomed. Helicobacter refluxes in saliva, ends up in your mouth, and that's how it's passed. And that's why there's clusters in families. And the story here is Professor Barry Marshall, and he's done one of the podcasts, which is really entertaining to listen to, and Robin Warren, and they got the Nobel Prize 20 years ago, but this was a Nobel Prize project they were doing the research into helico, and they knew that it's found in all mammals. All mammals have Helicobacter. So they thought, well, that's easy enough. We'll get some rats. Sorry about the rats. We'll infect the rats. No infection. Okay. We'll infect guinea pigs. They're like humans, aren't they? They need vitamin C and things like that. Oh, dear. No infection. So they, persevered a bit longer. They had to go infecting pigs. No infection. So Barry Marshall was getting a bit desperate by this time and thought, well, there's only one thing for it. So he drank 2 Petri dishes of Helicobacter broth himself, and immediately started to feel very sick, very gippy, and the most awful halitosis. So he thought, oh, now, what am I going to do now? So he decided he'd go home and tell his wife what he'd done. And she was horrified. And she banned him to the spare room. She said, do not come near me. He said, you just smell horrible. So that was a bit of a sad story. But the good news is he's got his boss to endoscope in the week after. He found that his stomach was absolutely teeming with Helicobacter, so they've got lots and lots of biopsies. And from that, they were able to establish the early work on Helicobacter and sensitivities and antibiotics, and they started to unravel a lot of the science behind this special bacteria. So it is an interesting bacteria, and it's important because, learning point, it's a class 1 carcinogen for gastric cancer. It's microelpheric, so in other words, it doesn't live in the deep layers of the muscle. It doesn't live in the middle. It lives in the mucus that's lining the stomach. It sits on the surface. So it's a bit like dermatology. It's a bacteria sitting on the surface of a skin. The diagnosis, now, Sheffield has always used the stool antigen, and it's a much better test than the serum markers and things like that. We use stool antigen. The treatment, traditionally, PPI and 2 antibiotics, and it's all in the BNF. And sometimes at endoscopy, people send a referral and say, well, we've had 2 lots of antibiotics and it's not clearing, we're still positive. Well, if you look in the BNF, there's a 3rd and a 4th line. And if you give more different antibiotics for longer periods of time, you will get increased clearance. So you should have perhaps had to go at 3 different regimes before referring. We can do sensitivities and biopsies, and then send you back with like a bit like a midstream urine, so you can make a bespoke cocktail for that patient. But new treatment, and this is NICE approved, and it's bismuth. So bismuth is the game changer, and we haven't been able to get Denol for years, and Denol is the one that really knocks Helicobacter on the head. It's combined with metronidazole and tetracycline, and it's a 10-day course. Now, for that, it costs about 50 quid, I think. But if you're going to clear it in one, it's actually very cost-effective. And it's new. It's new to the UK. They've had it on the continent for years, so we're a bit slow catching up. It's called Pylera, and it will clear that resistant Helicobacter that's been defying us so far, without sending them for an endoscopy. So try that first. So when it comes to retest, this is a question we sometimes get asked. You've got to leave it for 4 weeks because the Helicobacter dead bodies will still be present and they will throw the test positive. So you've got to wait for 4 weeks to get them all washed out before you do another stool antigen test. So 4 weeks after a treatment course has completed. Or you put a cytosponge down if you want. So the future for Helicobacter actually looks quite bleak because it's reducing by 50% every 20 years. So soon it will be eradicated and gone. So the learning points there, Helicobacter, special little organism. It's got like a blade on the top of its head, which is why it's called Helicobacter. There is a new treatment available which is much more effective than any of the regimes that we've got currently that's in the BNF. Right, so we're moving down the bowel, we've done the esophagus, we've done the stomach, we're now into the small bowel. Celiac disease. 1% of the population. So a lot of people have got celiac. This early work was done by Dave Sanders, and he actually came and sat in our surgery waiting room and asked members of the public, please can I have a blood test? And they all said, oh yeah, do what you like. and that's how these figures were established. And it's still, you know, agreed that that is the case. But what is now recognised is that there's another, you know, it's a bit like the iceberg. We know about 1%, but there's another whole lot sitting underneath that are on our lists, and they are slipping through our fingers. The average age of the diagnosis of celiac is age 45. It's not the child with a fat tummy. It's not the teenager with failure to thrive. It is people age 45. Nice guidance has said these are the people we need to be looking out for, when to suspect. So within a group, well, if you look for anybody who's got iron deficiency, 3 to 5% of them will actually be celiac. And wouldn't you rather have celiac than cancer? So, you know, this is the message. Somebody with iron deficiency, you must check a celiac antibody. They're tired all the time. You know, we see these people all very frequently, don't we? The people who are tired all the time, chronic fatigue, ME, a proportion of them will be celiac. Now, here's a quick project if anybody's got a registrar who needs a job to do. Within your group of people who have got a diagnosis of IBS-D, irritable bowel with diarrhea, 16% of them are likely to have celiac disease. So that is quite a thing, and that's been repeated time and time again, that there's a lot of those IBS-D people who are actually celiac. And we know about poor growth and late puberty and osteoporosis, easy bruising, recurrent mouth ulcers. You know, these are the presenting symptoms we're fairly familiar with. And I just wanted to take you back in a bit of history, a bit of culture in the afternoon, because we've not always known about celiac. And if it goes back to 1930, Dr. Haas, he just realised that in Puerto Rico, in the towns and in the cities, a lot of people had celiac. Whereas in rural, very few people had celiac. And the answer is bananas. Because if you have wheat as your carbohydrate, you start with celiac. If you have bananas, there's no gluten in bananas. And then the next piece of the jigsaw puzzle came just after the war, when this guy was a paediatrician looking after the celiac ward in the Children's Hospital in the Netherlands. And every time the Americans had an airdrop of food, all the kids on his ward got a lot worse. And the reason was they were then eating lots of wheat and grains, unbeknowing, and their health deteriorated. And that's how they connected it with the gluten, that's the protein in wheat. So celiac is actually an autoimmune disease, and it runs along immunological lines. So affects the bowel, and we know that we test for IgA. We look at that transglutaminase, and 3 things are essential. One is the gluten, which is the thing that annoys the bowel. Secondly, there is a genetic susceptibility. And all these people are HLA, these are the HLA typings, DQ2, HLA8 actually, DQ2. But there's a lot of overlap. And thirdly, there's some sort of trigger, and it's the trigger that we don't understand. Why are people presenting at age 45 with celiac disease when clearly they've got the same genetics that they were born with? Why are they now starting to develop an iron deficiency anemia? And that's the bit of the jigsaw that still get to be unravelled. Nobody knows what it is that throws that into activity. There's associations that, you know, just for your brain. There's a 10% link with the autoimmune. So Dave Sanders went and sat in the diabetic clinic and got people's blood, and he realised there's a 10% autoimmune link: thyroid, diabetes, rheumatoid arthritis, Crohn's disease, ulcerative colitis. All those autoimmune things are all linked together, and there's an increased incidence of celiac disease in them as well. Turners and downs, just for completeness' sake. Okay, so when you eat gluten, you get that activation of the immune system, inflammatory response, up go the lymphocytes, and that then causes the villus atrophy. That causes the malabsorption, bloating, pain, diarrhea, the symptoms that we know and recognise as celiac presentation. But the thing, and this is possibly new, those tissue transglutaminase antibodies, there's 3 different types. There's different receptors in different places, and in the skin, there's type number 3, and that presents as dermatitis herpetiformis. So you think, well, it's really bad eczema, really, really itchy eczema. And all the time, it's part and parcel of a gluten enteropathy. Very itchy, extensor surfaces. 90% of those people have celiac disease, and it responds to a gluten-free diet. The other place, and I didn't know this, in the reproductive tract, we always say, well, you can't get pregnant because you're short of folate. Well, it's not. It's because type 2 receptors are in the uterus and the fallopian tubes, and it causes an autoimmune response, and the implantation does not take place. Unexplained fertility, infertility. Response to a gluten-free diet, cheap. And the last one, which again was worked out by Sheffield, Professor Haji Vasalu and Dave Sanders at the Hallamshire Hospital, there are these receptors in the peripheral and the central nervous systems. So if it's peripheral, you present with a peripheral neuropathy and ataxia, because the Purkinje fibers in the cerebellum get laced with these little antibodies, they degenerate, and that's it, you're wobbling all over. And it responds to a celiac gluten-free diet. So that's, 3 places that you wouldn't have expected celiac to be influential in. The diagnosis, when I worked in clinic, they said you've got to have 6 slices of bread every day for 6 weeks. Well, I don't know anybody who eats 6 slices of bread a day, end of. So now they say, well, actually, 1 or 2 slices of bread a day will be fine, or 1 gluten-containing meal every day for 6 weeks, and you'll get a decent biopsy with a definite yes or a definite no. Remember that 2% of people are short of IgA, and it's an IgA-related antibody, so remember the IgG route. And during COVID, the British Society of Gastroenterology approved the non-biopsy pathway, so that if the tissue transglutaminase is more than 10 times normal, so over 70, that's it, that's your diagnosis. They also have to be EMA positive, under 55, and no red flags. So there's a non-biopsy pathway, because sometimes people just adamantly say, I am not having an endoscopy. You'll have to give me a general anaesthetic if you want me to have one of those. So you can do it like this. It's perhaps not as pure, but that is now accepted as an alternative. Right, so we're moving down a bit now, and we've got as far as the liver. Now, I don't know if you remember, but about 4 years ago, the PLI did include cases gastro, and we talked a bit about liver. Well, I just want to mention one thing, and that's hepatitis C. And this is a good news story for primary care. Liver disease is silent, isn't it? We don't know that we've got it. A lot of people might have it. But there is a new curative treatment for hepatitis C. And this was a Nobel Prize in 2020 for identifying the virus. At that point, the prevalence was 1%, but it's already down to 0.4. And this is due to the good work that our colleagues at Likewise, who I was just talking to earlier on, are engaged in. Case finding for people who've got hep C, but for whatever reason have gone under the radar. There's 50,000 patients in the UK still to find. So in Sheffield, there's going to be 500 patients. So if there's 100 general practices, there's 5 in your practice that you've got to find. The World Health Organization reckons that this disease can be eliminated in the UK by 2025, so we've got to get a move on. Risk factors, well, we all know this. Liver function tests, intravenous drug use, migrants, blood transfusions, transplants, anybody with any other blood-borne virus needs checking for hepatitis C. And I'll tell you a sad story about Egypt. So probably about 20 years ago, there was a big problem in Egypt with schistosomiasis. So they sent the public health teams out with one needle per village to inject them all against schistosomiasis. So the resultant of that was that 15% of people in those villages in Egypt ended up with Hep C. Anyway, they're working on it, they got it right down, and it's just a sort of a moral tale, that one. That's the schistosomiasis story. The risks of the disease, onward transmission. Anybody who's got Hep C and they don't know about it, they're going to pass it around the family. The liver becomes fibrotic, cirrhotic, and then, of course, hepatocellular carcinoma. The new bit that I want you to take home, the take-home message, is there a self-testing portal, and that's the address, hepc-test.nhs.net, and you can send away for a poster that you can put on the wall in the waiting room. It's got a QR code. Patients can scan it, send away for a saliva swab, which they post off, and if they turn out to be Hep C positive, then they send somebody to sort it out. So that's quite an easy thing that we could all do in a very discreet way. Just an oral swab. So the treatment, and this treatment can be delivered from anywhere, likewise from a GP surgery, from the health bus. It's an oral tablet, directly acting antivirals. It's a bit of a weedy virus, apparently. Clearance is easy. 1 pill a day for 12 weeks, 3 pills a day for 8 weeks, cure. So it's nothing like the old-fashioned interferon that we used to use and made people very poorly and aches and pains, and they never completed the course. This is potentially an 8-week curative course. No monitoring, you can give all your medicines all at the time, don't fight with anything. No matter what you're on or what you've got, everybody can have it. Even if they don't finish the course, the clearance seems to be very high. They all get a review at 3 months, and 99% is completely cleared, including people with HIV. So, it is a game changer potentially. But we've got to find these people. There is a big move afoot which is coming out from the Cancer Prevention Programme, and they're sending out a man with a van to scan. And they'll be coming out to GP surgeries. So if we've got anybody with any liver disease or any Hep C, the idea is that we can send them immediately for a scan to see if they've got cirrhosis that they don't know about. And that's a project that I'm talking to some of the liver people about on Thursday of this week, that we might be able to get going locally. So that's hepatitis C. So the take-home message there is, it's curative, it's easy, somebody else will do the work, don't involve us. All we've got to do is find the people who would benefit. So anybody who's got Hep C or ever had Hep C and perhaps didn't complete the course of treatment or anything, then get them on that self-testing portal, check the saliva, and then somebody else will do all the work. So moving down into the bowel now, we're nearly at the end. Bile acid diarrhea. Now this is really small print stuff, except that it's not, and I'll explain why. 1% of the population have it, and this is as big an area of gastro as is celiac disease, 1%. And it's as big as UC and Crohn's combined, and yet we never even hear about bile acid diarrhea. Patients say there is a very poor understanding in primary care, and that reminded me of menopause. Here we go again, GP bashing. And that there's a 5-year delay in diagnosis, which, this is what the patients are telling us. The symptoms are watery diarrhea, between 4 and 12 times a day, but also at night. Now, there's not many people that get up in the night for diarrhea. They're nearly always early morning, yeah, and it's urgent, yeah, but not in the middle of the night. Everything you check is clear. You do a culture, you do a fecal calprotectin, you do a FIT. Everything is clear. So the physiology is that there's just too much bile acid. The liver makes it, puts into small bowel. The idea is that it's there to digest the fat and get it reabsorbed into that enterohepatic circulation. But if it's not properly reabsorbed, it dumps it in the colon, and it's very, very irritant. So the colon hates it, shoots it through, and that's the origin of this watery diarrhea. if anything happens to the small bowel, which is where it's getting reabsorbed from, so say a friendly surgeon takes it out, they will then get bile acid diarrhea. If you have a very rich lifestyle and you have too much cholesterol producing foods, so overproduction, dumps it in the colon. And type 3, and I think this is the take-home message for us this afternoon, after a cholecystectomy, 1 in 10 people get bile acid diarrhea. So, you know, cholecystectomy, common operation, 2 or 3 years down the line, everybody's forgotten that they've had the gallbladder out, awful diarrhea. Well, it's IBS. It must be IBS-D. Oh, yeah. But it's not. Potentially, is it bile acid diarrhea? So the diagnosis is CCAT scan, which is a hospital job, and they look at, you know, they give them some bile acid and see how much is still there after a week. But there's obviously a long waiting list for that, so you can just do a trial of treatment. And Kumar Basu is quite keen on this. So basically, if you think, well, it might be, I've nothing to lose by trying, the medicines that you could try would be cholestyramine, cholesevelam, cholestyramine. But watch out for this one, Questron Light, which of course is cholestyramine, but it's full of aspartame to keep the calorie content down. Aspartame causes terrible diarrhea. So avoiding Questron Light, any of those others would be a suitable trial for maybe a month. One tip though, if anybody takes the contraceptive pill at night, alongside their cholesevelam, cholestyramine, it will knock out the pill. So don't let them take it. It's got to be on an empty stomach without any other medication because they'll malabsorb their other medication. Diet, low fat. So in a nutshell, that's bile acid diarrhea. So first thing you've got to do is think about it. Bile acid diarrhea. And if you think, well, do you know, it might be. You've done all the tests, they're all clear. Send them off to gastro, 35-week waiting list. Yes. You've nothing to lose by doing a trial of treatment. Bile acid diarrhea. 1% of the population is quite a lot. So we're still down in the colon. We're getting to the very end now, diverticular. So in September last year, you know, we're really up with the leading edge here. Some new advice from NICE about diverticular disease, saying, actually, you can have as many seeds and nuts as you like. Packet of popcorn, eat the whole lot. There is no evidence whatsoever that nuts, seeds, popcorn make diverticulosis any worse. So that's new from NICE. On the other hand, there's no firm evidence either that increasing fibre makes it any better. So what do I do then? Increase fluids and a trial of fibre gel. That is what they advise on this new NICE advice. So who's got diverticular? Well, anybody in this room age 40? 5% of you have got it. 30% if you're 60. And 60% of people over 80 have it. So people come to clinic and we say, well, it's wear and tear on the bowel. You know, the older you get, the more diverticular develop. It's often associated with lower socioeconomic groups, and same obesity, smoking, lack of exercise, it's all in there. The other interesting thing, in the West, you know, the West, it's in the left colon, but in Japan, it affects the other side of the bowel. Now, why should that be? So nobody knows. What causes it? Well, there's something here about genetics. There's something about the microbiome, which we're going to talk about in a minute. There's something about diet, lifestyle. Well, what is it? These little pouches along the wall of the bowel. I talk about blowouts on a tyre. And because of that inflammatory, you get extra collagen, and it makes the bowel very, very stiff. And if you're passing an endoscope up, it's really, you know, you're having to really push and shove because the bowel isn't flexible and rubbery like a tube. It's very stiff. And then what happens? Well, in those little pockets, you get infection, and that is then diverticulitis. So there's an infection on board. You might even get an abscess, which is bad news because that can perforate, peritonitis, or it can bleed. And a lot of people now are on DOACs, Non-steroidals, aspirin, steroids, all things that increase the bleeding risk. So if anybody's got diverticulosis, develops diverticulitis, but they're also on aspirin, they're at risk of a bleed. Having said that, only a small proportion develop problems. So if people have got it, only 15% are going to run into trouble. And they usually come in and they say, Doc, it's that pain, it's down on this left-hand side, I've got it again, I need my antibiotics. Dr. X always gives me antibiotics, and there's this really faith, if I have antibiotics, I know I will be better. But the guidelines are saying, don't do that, don't do that. So this is the link that, if you want, and the slides will be available, won't they, after a bit. This is the link that takes you to these pages here that can't expect anybody can see any of that. But that's where it's all written, all about this diet, all about the microbiome, all about genetics, all about don't give antibiotics. It's all on there because, you just think, well, I always give antibiotics. I feel comfortable if I give antibiotics. I know it's going to fix them, but we shouldn't be giving antibiotics at that first presentation. That's page 2, which talks about which antibiotics if you're going to give one. So what NICE is saying, we've got to examine the patient, you've got to put a hand on the tummy. Have they got tenderness? Have they got rebound? Is there something serious going on? And then we check a blood test. What's the CRP and what's the ESR? And on the basis of that, you can make a decision whether you should or shouldn't have antibiotics. So you send them away with paracetamol and Buscopan. So they'll feel really shortchanged. Oh, I like antibiotics. No, paracetamol. And then you watch and wait. And that's very, very difficult because we're all busy. You want to do it, finish it, get on to the next one. So we're carrying risk. But do you know what GPs are good at? Carrying risk. If the CRP comes back very high, then yes, there is a diverticulitis and they do need antibiotics. And if it's very high, then you're worried about a perforation or an abscess and you need to admit, and they'll do a CT scan and just see what is going on. So if they're poorly, pain, fever, malaise, sweats, CRP raised, you're going to give them probably comoxiclav unless they're allergic, and, oh dear, that's it, you've done it. You've given them an antibiotic. Spare a thought for the microbiome. Oh. Last word's got to go to Tim Spector. Yeah, everybody knows Tim Spector. He would have us spend our lifetime perfecting these plops, ameliorating the microbiome, eating 30 different plants per week. Well, luckily, tea's 1, coffee 1, red wine 3. So you've only got 27 to find, including fermented foods. Right, fermented foods, such as kimchi and sauerkraut. And now we've gone and given some antibiotics. Oh dear. So this is a picture of your bowel with lots and lots of lovely, lush growth, 1 million species, vibrant, growing, thriving, everybody very happy. And now, look at that. There's one tiny little culture of C. diff at the bottom, ready to reproduce. So now, ladies and gentlemen, this is the end. What did the kimchi say to the sauerkraut in the colon? Thank you for listening. Watch out, there's an antibiotic about. Thank you for listening.